right, good morning, everyone. We're excited to be here today presenting on structural options for the no option patient. I have no relevant disclosures. My only disclaimer is that I will be presenting a lot of investigational devices and a lot of the work that we're doing here at MHI. I want to thank MHI and MHIF for the opportunity to be here this morning and be presenting our work. And as always, I'll start with a case. We have an 81-year-old male who has been having shortness of breath and dyspnea exertion for some time now. He underwent a successful TAVR 6 years ago with the placement of a 26 millimeters S3, which is currently well functioning. He had persistent atrial fibrillation, for which he underwent an AV nodal ablation and a single chamber pacemaker, mild non-obstructive coronary artery disease, hypertension, diabetes. He currently has NYHA 3 symptoms, and despite his GDMT with metoprolol, lisinopril, and empagliflozin. And you can clearly see what's happening. He has a mild to moderate reduced ejection fraction. He does have a calcified mitral valve with a small flail segment, calcification extending to the tips of the leaflet as well as the subvalvular apparatus. That leads to eccentric severe mitral regurgitation, and you can appreciate on 3D the small flail segment as well as the reduced mitral valve area. And he currently has a mitral valve gradient of 3 millimeters. We further evaluate with a cardiac CTA, and you can clearly appreciate the heavy calcification of the annulus with a really elevated max score of 7 that expands all the way to the posterior leaflet. So we chatted with our surgical team. They felt really appropriately that he's at a really elevated surgical risk. So now what? And we're going to come back to it a little later in our presentation. So mitral regurgitation is the second most common heart valve disease in Europe and the US. Its prevalence increases with age and can reach all the way to 90% in individuals more than 75 years of age. And although surgery has shown very favorable outcomes when it comes to primary mitral regurgitation, the data are not there for secondary mitral regurgitation. What we do know for sure, though, is that the optimal timing of surgery for mitral regurgitation is before you start having LV dysfunction and symptoms, and that's been very clearly demonstrated in studies. Following that, the guidelines have been pretty clear that when it comes to primary mitral regurgitation, when this context of symptoms, mitral valve surgery is the first. It has a class 1 indication. When you're looking at no symptoms, then it depends on whether LV dysfunction has been established or not. If it's present, then surgery is also a class 1 indication. With a class 2A indication, when there is normal LV function, but there is the option of a mitral valve repair in a center of excellence. There is definitely room for transcatheter edge-to-edge repair for patients at high or prohibitive surgical risk. And moving on to secondary mitral regurgitation, as I said, the picture is a little different. So transcatheter edge-to-edge repair is currently getting a 2A indication when looking at patients with decreased LV injection fraction. And that's primarily driven by the findings of the co-op trial, with mitral valve surgery kind of reserved for patients with normal EF or patients that are not candidate for CLIP. And mitral tricuspid edge-to-edge repair has done a lot of progress over the years with really favorable outcomes, and it has been successful in tackling a lot of heart pathologies. Nonetheless, there still remains an area where mitral TEER has not been, at least for this point, shown to have favorable outcomes. Patients with small mitral valves area, patients with calcified leaflets, patient with prior rheumatic mitral stenosis, as well as when there is a cleft or there's concentric MAC with stenosis, are the ones we're trying to clip can actually give some optimal outcomes, and replacement is always coming to the picture. Despite all this, what we do know is that up to 50% of the patients with mitral regurgitation and an indication for intervention, they will not receive treatment. And that's been shown in 2 studies in Europe, 10 years apart. And a lot of it is the result of the risk factors that come with the mitral disease. So looking at characteristics of patients that are denied surgery, these are things that we see every day on the floor. So these are patients that are older, patients that have a higher comorbidity, and patients that have lower ejection fraction. A very specific subset of that population is patients that have mitral alveolar calcification of MAC. The prevalence of it is about 5 to 42%, depending on the series and depending on the study that you're looking. Most commonly, it will affect the posterior leaflet, and in only 1% of the patients, you will see a circumferential calcification of the annulus. Severe MAC can lead both to mitral stenosis and/or mitral regurgitation, and it definitely poses a lot of technical difficulty for surgeries. In the surgical literature, there's two different terms: resect, which is the attempt to remove the calcium when the attempt for decalcification, and respect, which is working around the mitral calcification and either putting a valve in an intra-atrial position or trying to use an extracardiac valve conduit to be able to bypass the mitral calcification. Nonetheless, both strategies are associated with higher risk of complications, and they pose a true limitation to our surgical options. As a result, dedicated transcatheter mitral valve devices started coming into play. There's a lot of different technologies out there with different delivery options, whether that's transapical or transeptally. The majority of them are actually deployed as one piece, as one valve, and there are currently 3 devices that are deployed in 2 steps. So you have a device anchoring first mechanism, and then you do bring the actual valve itself inside it. Tendyne was the first device actually to be investigated, and it's the one with the most data currently. It was delivered transapically. It consists of the valve, a tether mechanism, as well as an apical pad that will cover the apical access point. It has a D-shaped design, which is similar to the valve design. And it was heavily studied in the Summit Tendyne trial. Summit, it was designed into having multiple arms. There was an arm that would, for patients that were amenable to MitraClip, and it would a patient would get randomized to either receiving Tendyne or MitraClip, and that group actually closed in 2023. There was a group that would have severe MAC, and they were not eligible for MitraClip, and that was the severe MAC cohort, and that completed enrollment, and we're currently having the Tendyne MAC continued access protocol. And you also had an arm that did not have MAC, but it was a non-repairable cohort, and that also closed. Looking at the 1-year results for the rolling subject, that included the 2 patients per side. Survival was 74.3% at 1 month, with excellent decrease in the MR severity, with the majority of the patient having mild or less. And that translated to improved NYHA classification as well as improvement in the KCCQ overall score. Moving on to the severe MAC cohort at 30 days, procedural survival was 98.1%, with 5.8% of the patients requiring emergency surgery. And at 30 days, we had a 6.8% all-cause mortality and a 21.4% major bleeding, with overall good outcomes in a very complicated and high-risk population. Similarly, MR grade was less than mild in 100% of the patients, and improvement in NYHA classification was seen at 30 days. Our second option is Intrepid, and why is that different is that originally it started in being a transapical valve, but now it's a transeptal valve. It anchors itself using multiple small cleats in a cork-like effect, so you don't need that apical pad anymore. It has a symmetrical design, so it's more circular, and it eliminates the need for rotational alignment. And it has an outer stent and an inside inner stent, which houses a 27-millimeter tri-leaflet bovine pericardial valve. It comes in 2 sizes currently, with a 3rd size coming in, and originally was placed over a 35 French delivery system, and there will be coming out very soon with a 29 French system. Intrepid was tested in the Intrepid EFS early feasibility study with very good 1-year outcomes, 6.7% all-cause mortality at 1 year, significant reduction in the mitral regurgitation. You see 96% of the patient having none or trace at 1 year, and only 4% having mild. Also improvement in NYHA classification, with most patients being at NYHA2 and NYHA1 class. Currently, Intrepid is being tested in the Apollo pivotal trial with 2 arms, the one being the primary cohort and the MAC cohort, which looks specifically at patients with MAC. And there's rolling subject in both arms. Moving on to Sophia. These are all like different valves with different designs. Sophia has a dual disc circular design. It anchors by compression and radial forces. It's a low profile system and it's fully repositioned and recapturable. Currently, there is very limited data coming out of the Sophia EFS, including only 10 patients with excellent outcomes. But again, as I said, this is a very early stage data. Similarly, when looking at MR grades as well as NYHA improvement, with all very favorable results. I will be shifting you to a totally different valve, which is actually based over here in Minneapolis, called the Alta valve. Completely different design, supraannular, minimal protrusion to the left ventricle, which minimizes the interaction to the normal with the normal LV, as well as the interaction with the mitral valve apparatus. It is actually anchored by oversizing cage inside the left atrium. So that allows it to sit in place without really affecting the native mitral valve a lot. It is parallel to the outflow tract, so it allows it to minimize the chances of obstructing the outflow tract. And although originally it was designed to be placed transapically, it has now converted to transeptal approaches. And it is part of an EFS trial, and as a team, we had the luck late last year to be actually to be performing the first fully percutaneous transeptal Alta valve in one of our patients. When none of your TMVR options are really there, there's always the option of actually trying to use one of our commercial TAVR valves into overexpanding it and positioning into the mitral location. And that was actually investigating the mitral trial, which included patients receiving either the SAPIEN XT or SAPIEN 3. It had 3 arms, looking at placement of a valve inside a prior mitral valve, a valve in ring, or placing a mitral valve inside native mitral valve with severe calcification. The majority of the patients did receive the SAPIEN 3 valve, with only a small part of them receiving the prior generation SAPIEN XT. And you can see the MAC arm, which is the most complicated arm of all. It did actually have a higher cumulative mortality of 33%. At 5-year follow-up, the valve-in-valve group had really favorable results, 79% survival, compared to the valve-in-ring and valve-in-MAC that had like significantly lower, who actually describes also the complexity of those patients and the high-risk state that they are in. Most importantly, out of the mitral trial, a lot of things, we learned a lot of things. And the main thing is that the mitral annual calcification positioning actually matters. So mitral annual calcification score was designed taking into account whether it's calcification in the distribution of it, the thickness, whether the trigones are getting involved or not, as well as whether the leaflet. And as a result of that, you can see that higher MAC scores were associated with a lower chance of valve embolization and migration compared to lower MAC scores that would lead to a really high risk for embolization. So mitral 2 pivotal trial has been designed, which is primarily targeting patients with valve in MAC, high MAC scores, 100% transeptally, and we'll be comparing patients to the those that do not receive any intervention and just proceed with natural history. And it's currently enrolling, and it's about 80% completed enrollment. Despite of all the options we have, our biggest limitation is screen failure. This is actually data from our own team here at MHI showing that 89% of the patients that we screen for TMVR actually do not get enrolled in any of the clinical trials, and because of either anatomical reasons, clinical risk exclusions, or just futility. And in our data, we've shown clearly that not being able to receive any therapy is actually associated both with worse outcomes as well as more frequent rates of hospitalizations and higher mortality. Same data we're actually presenting out of the big clinical trials. So looking at Intrepid, 37.3% of the people actually got enrolled, whereas more than 60% of the patients were actually screen failed either to anatomical risk factors or concern for LVOT obstruction. Moving into Sophia, same numbers and same data, higher failure rates, and most importantly, if you look at the colors, issues with the valve design and sizes is actually the primary reason why people fail. So 54% was annular dimensions, 10% was issues with the neo LVOT, 7% was issues with sealing. And that creates the current challenges that we approach with TMVR therapies. And those are anatomical challenges, which have to do with the sizing of the valve, the interaction with the LVOT, as well as the fact that we're dealing with various anatomies. Mitral valve is not one anatomy, it's different anatomies, different pathologies, and we have to be able to address all of them. Device challenges, whether that's leaflet thrombosis, need for anticoagulation at least for a period of time, as well as anatomical interference. And then procedural challenges. These are complex devices. These are not easy to be deployed. It requires expert imaging, especially at the level of intraprocedural TEE and CT to be able to actually deploy those valves. And a lot of those patients are already too high risk when they start the process. And as a field, we've learned that pretty well, and we're trying to start to adjust to the difficulties and limitations that are coming up there. And we start trying to find solutions. LVOT obstruction is actually one of the biggest problems we're faced with, and that can be happening either as a result of the displacement on the anterior leaflet of the mitral valve towards the LVOT. We have developed strategies in order to be able to prevent it, whether by reducing the size of the atrial septum, by performing alcohol septal ablation, radiofrequency ablations, or transcatheter myotomy using the sesame technique, or by actually taking care of the anterior leaflet itself. We can either lacerate the anterior leaflet using the lampoon technique. We can surgically resect the anterior leaflet in what we call a cytral, which is like a combined procedure where a surgical team will resect the anterior leaflet and then proceed with the placement of a balloon expandable valve. And last option, which we've kindly started using, is the Batman technique. And I know most of you listening to the Batman technique think of the superhero coming and kind of eliminating the anterior leaflet, but that's not what it really stands for. So Batman technique is a balloon-assisted translocation of the mitral anterior leaflet. So what we do in reality is we go across the anterior leaflet of the mitral valve, and we balloon it, so we translocate it away from the LVOT, and then we proceed with the placement of a commercial TAVR valve inside the mitral position. And this is one of the cases that we recently performed with the Batman technique, showing excellent mitral valve function and minimum mitral valve minimum interaction with the LVOT, with a mean gradient of 14 millimeters of mercury. Our team performed that recently and we had the pleasure of having Dr. Tarek Helmi, who's one of the providers to first describe this procedure. And as I said, we had the pleasure to perform one of the first fully transeptal transcutaneous Batman procedures. So with all on in mind, I'm sure I've already complicated things for you, and this kind of simplified attempt to go through how we approach treatment of whenever we see a patient with severe MR or severe MAC. So Always the first question is, can this patient have surgery or is he a TEER candidate? If the answer is yes, then that is the route. If the answer is no, that's when we start looking at what else can we do. And the first thing we'll look at is this a patient TMVR candidate? If yes, then we'll submit him for our TMVR options and try to go forward with a dedicated device that's been shown to have more favorable outcomes. If the answer is no, then we'll look deeper into why is that patient not a candidate. Is it because there is a high risk for LVOT obstruction? And if that's the case, then we'll look for LVOT modification options, which I already showed you, and then try to reassess the candidacy. If not, then we'll look for options of placing what we call a valve in max. We do a valve inside a mitral and calcification with a possible modification of the LVOT if needed or not. And if that's not an option, then we'll look at other factors. Whereas is high-risk surgery still an option? Would surgical removal of the anterior leaflet be an option? And if not, if all else fails, then medical therapy is the way to move forward. So moving back to our patient, we decided to proceed with a transseptal alto valve. And a lot of you, if you've seen some of our procedure, you'll know a lot of the times we'll do a lot of 3D imaging to make sure that when we orient our transeptals, we can make sure we have adequate height. We make sure we're oriented on top of the mitral valve to create a more coaxial plane and a more favorable anatomy. So we proceeded with balloon septostomy, and we did the valve deployment in 3 steps with the original valve placement across the annulus, following by the cage deployment and the device release after making sure that we don't have any significant valvular or paravalvular regurgitation. And since these are big devices, we frequently will assess for atrial shunting, and if we do find evidence for closure or for necessitating closure, we'll proceed with it, and which is what we did in this case, where we proceed with AST closure through actually the device struts itself. And you can see in our imaging at the end of the procedure, excellent valve function with only trivial paravalvular regurgitation, no flail leaflets anymore, grade mitral valve area, and a mean valve gradient of 2 millimeters of mercury. And I'm pretty sure you all remember how calcified that valve was and how severe that eccentric mitral regurgitation was. Shifting to a different side, I have a case of 84-year-old female with severe symptomatic both mitral regurgitation as well as torrential tricuspid regurgitation, heart failure with preserved ejection fraction, recurrent hospitalizations for heart failure exacerbation despite being on optimal medical therapy. Originally, we decided to proceed with a mitral clip with excellent result and reduction to mild. Nonetheless, the symptoms continue to persist despite the resolution of the mitral regurgitation. Patient was in GDMT, stable dose of torsemide, currently in NYHA class 3, and as we expected, a high surgical risk. We did perform a right heart cath showing well optimized when it comes to the fluid status, nonetheless severe symptomatology. And it's pretty evident why the patient is still very symptomatic. And you can see this tricuspid valve with a torrential TR, the presence of a pacemaker lead across the tricuspid valve, which is currently located centrally, and it is moving more central anterior septal. And you do see the tricuspid regurgitation originating primarily anterior septally and in the central location. So tricuspid regurgitation is actually the most frequent valvular heart disease in the U.S. The numbers are pretty shocking. It's expected to affect 1.5 million people, and it's expected to have a yearly incidence of about 200,000 people in the U.S. and more than 300,000 patients in Europe. The biggest limitation of tricuspid regurgitation is until recently, we did not have a lot of therapeutic options, with medication and diuretics being our own. And the severity of it is very easily underestimated, as patients can live for many years with volume overload without really endorsing any significant symptoms. 90% of the tricuspid regurgitation that we see out there is secondary, with only 10% of it being primary. You do see a little star next to it, and that's because that's expected, the number is expected to go up, and that's coming from the leaflet damage that occurs with pacemaker devices that go across the tricuspid valve leaflets. So the 10% is actually expected to be a little bit higher. And looking at the anatomy of the tricuspid valve, you can clearly see it's a completely different valve compared to the mitral. So tricuspid valve has a non-planar morphology, with the highest points being in the anterior-posterior direction and the lowest points being in the medial-lateral. When the patients start developing functional tricuspid regurgitation, they will develop a more planar annulus that dilates in the anterior-posterior diameter, and it loses that normal saddle-shaped configuration that it has. Tricuspid regurgitation is poorly tolerated, and it is actually shown in multiple studies to be associated with worse outcomes compared to masked patients that do not have it. And that's been shown also in a VA study that's been performed over 4 years, and it showed that severe tricuspid regurgitation is actually associated with worse outcomes compared to any other form of tricuspid regurgitation. Surgery has been the only option for tricuspid regurgitations until recently, and there's been a lot of different numbers actually circulated about what are the true outcomes of surgery and how frequently is it performed in the US. There's numbers out there that go up all the way up to 10% for mortality from tricuspid valve. And these are actually the most recent data that Dr. Turani actually presented at the Society of Thoracic Surgeons meeting a few months ago, showing that there's about 2,000 cases of isolated tricuspid valve surgery performed currently in the US every year, with an outcome of about 5.5 to 6% mortality. And this will actually be impressed pretty soon. Nonetheless, it is unclear even if tricuspid valve surgery is actually helping. And there is longitudinal echocardiographic data showing that over the way up to 20 years, survival between surgery and medical therapy is not that different. And what we do know for sure is that repair is better than replacement. So if you can repair the valve, that's going to be better, but it's not clear if in the long run you'll be any different compared to pure medical therapy. As a result of all that, there's no Class 1 indication for isolated TR therapy right now in the US. The only Class 1 indication is in combination of left-sided surgery. That clearly describes the fact that we needed a change and we needed to better understand tricuspid valve before we can better address it. And a lot of work has been done in understanding how tricuspid valve works and why is tricuspid regurgitation so bad. So first step is actually be able to quantify tricuspid valve regurgitation, and we know that the scale in tricuspid valve severity does not stop at severe. It goes all the way up to massive and torrential. The second thing we know is that we don't have only 3 leaflets in tricuspid valve. I know that's what we always were taught in medical school. The tricuspid valve is a 3-leaflet valve, but in reality, we do know that there's different configurations ranging all the way from 3-leaflet, 4-leaflet, and 5-leaflet configurations with two anteriors, 2 posteriors, and 2 septal leaflets. And targeting different configuration can actually affect your outcomes, because now you have multiple coaptation planes that can affect how easy or difficult our ability to restore and repair the valve is. And continuing to grow, and this is our slide by our own Dr. Hamid, is our big 5 for success. So we started realizing that it's not only about fixing the valve, it's understanding what's causing the problem. So what are the gaps and how big are those gaps? Are there leads across the valve, and what's the interaction between the leads and the leaflet? How's our imaging ability? Is there shadowing? Is our horizontal hard? Will we be using intracardiac echocardiogram in order to be able to show it? What the anatomy is, and what other factors come into play? And as a result of that, similar to the mitral valve, we start having our green, yellow, and red anatomy, where we do identify patients that we feel repair is more achievable and it's going to be more favorable. And we do have the patients in the red where replacement might actually be a better strategy because anatomically trying to repair the valve would not be favorable. Looking at what options we have, actually there's a blooming number of devices out there that are currently being investigated in the tricuspid world. Most of them are trying to replicate what surgery does, whether that's an annuloplasty, whether it's a coaptation enhancement, orthotopic replacement of the valve, a heterotopic replacement, or the use of spacers. And for the sake of time, I'm not really going to touch on all of them because that would take a few hours, but I will cover pretty much the main devices that we're currently using. And I'll start with coaptation enhancements, and the two most commonly used being the TriClip and the Pascal. The TriClip, I'm sure everybody in this room is very familiar with it, and we're very familiar with the TriLuminate trial. TriLuminate trial, what it looked for is patients with severe symptomatic tricuspid regurgitation that were at least an intermediate or greater risk for tricuspid valve surgery. Patients were assessed by eligibility committees, both for suitability, adequate management, as well as the presence of severe pulmonary hypertension. And if everything else was cleared, then they were split into two groups. Those that we felt that they had the ability to have their TR reduced to moderate or less, and those that we didn't. If there was an ability to reduce to moderate or less, then they were randomized to receive either the TriClip device or a medical therapy. If not, they were enrolled in a single-arm cohort in order to evaluate the device and whether it's going to improve outcomes. For the TriClip, we used the newly redesigned TriClip G4 delivery system, and there were 4 different clip implant sizes used, and the study did meet its primary endpoint. Our own team over here and Dr. Sharaja actually presented those results at ACC in 2023, showing that MitraClip did achieve its primary endpoint of reduction in the composite of death, tricuspid valve surgery, heart failure hospitalization, and improvement in KCCQ by more than 15 points. And that was primarily driven by the increase in the KCCQ by more than 15 points. This was done in a context of safety with a decreased all-cause mortality of 0.6%. And as you can see, the third arm is actually the BRIGHT trial, which is the commercial trial for the tricuspid clip in Europe, where the device has already gotten CE mark. And you can see in the real-world data that low risk of mortality is actually maintained. Rates of major bleeding, there were 5%, and these are maintained in real-world data, with single leaflet device attachment of 7% in our clinical trial here, and 3.8% at places that have been doing it more frequently, which also shown an early learning curve for a lot of the operators when it comes to clinical trial. Most importantly, there was sustained reduction in the TR severity, with almost 89% of the patient achieving moderate or less tricuspid regurgitation at 1 year. And our own Dr. Calvacante has actually showed that this is actually associated with favorable physiologic remodeling, with reduction in the RV volume on CT, as well as improvement in the forward flow and effective RV ejection fraction by cardiac MRI. These all translate into sustained quality of life improvement with no waning effect over 12 months. And as a result of all that, that led to FDA approval of the device in early April, which also was kind of a big step in the trip of a lot of people here at the MHI and MHIF, starting all the way back in 2017 with the first in-human implant, then 2019 with the first TriLuminate case. A few weeks ago, April 2nd of 2024, when we performed the last TriLuminate case, and then a few days later with the first commercial case over here at MHI. Moving to the Class 2 trial, that's a trial assessing actually the use of the Pascal system It is a randomized trial. It's a 2-to-1 fashion comparing Pascal compared to optimal medical therapy alone. And currently, there's only limited data available. These are coming from the 30-day follow-up from the rolling cohort, and it shows a high successful implant rate of almost 85%, with significant TR reduction as well as improvement at YHA class and KCCQ score. The composite major adverse event rate is low at 8.7%. And I know the trial should be concluding very soon, so there will be a lot of more data coming in the next few months when it comes to class 2 and its functionality when it comes to tricuspid regurgitation. Moving to orthotopic replacement, the three main devices I will be touching on is Evoke, Intrepid, and Voudris. Evoke, I'm sure a lot of you might have already heard, has a unique valve design which engages the leaflets, the cord, as well as the annulus in order to secure placement. The anchors are atraumatic, so that allows it to interact with pre-existing leads as well as the native anatomy. It comes in multiple sizes through a 28 French transfemoral delivery system, which allows for multiple planes of flexion and depth control. And it was pretty much heavily studied in the TRISCEND 2 trial, which randomized in a 2-to-1 fashion the Evoke system comparing to optimal medical therapy alone. TRISCEND was a very unique study design based on the breakthrough designation. So it has 2 steps where the first 150 patients were assessed at 30 days, and 6 months, and the total cohort of the patient will be investigated for the full time of 1 year. Currently, we only have data from the first 150 patients and for the first 6 months, and these are the ones that are currently be presented, showing very favorable outcomes for 30 days, a cardiovascular mortality of 3.2%, a little higher risk of severe bleeding of 10.5%, and arrhythmia and conduction disorder requiring pacemaker in 14.7%. TR grade pretty much was almost close to eliminated. You can see a reduction, 98.8% was reduced less than moderate, almost 94% less than mild. And that translated to significant changes both at the KCCQ questionnaire as well as the NYHA and the 6-minute walk test all the way up to 6 months. As I said, these are currently the limited data we have. It did, though, translate into approval from the FDA for commercial use of the Evoke system, and I think the team will be presenting their full cohort data at the upcoming TCT meeting this year. So we will have more data available. Moving to Intrepid. Intrepid is a completely different mechanism. So similar to the valve that you showed for the mitral side, in that it has a circular inner stent that houses the 29mm tri-leaflet valve. It's being deployed through a 35 French transfemoral system, and it's available in 3 sizes. It has the ability to be implanted in the presence of pacing leads, and we do have cases done here that we've actually done it through in patients that are pacemaker dependent. And it does have a gap between the outer valve, the outer skirt, and the inner valve that allows it for a pacemaker to be placed. And it's currently at the stage of early feasibility trial. It's co-led by our own Dr. Papat, and we recently had the ability to place the first newly redesigned valve specifically for the tricuspid valve. And we're hoping to be able to get really favorable results at the end of the early feasibility trials. And last on the valve side, Voudris. Voudris is a completely different valve, and that's why I think it's worth taking a little bit of your time, in that it's not actually coming in on a straight, it's actually delivered on the side. So it is a completely different device configuration and setup, which is vertically folded instead of radially. In that way, it allows it to reduce its sizing. It's being delivered through a 28 French transfemoral system, and it has a double frame 9-needle prosthesis that houses a 30mm valve. There are 5 valve sizes that can treat actually anything all the way up to 180mm, so it can account for most of the higher anatomies compared to any other valve out there. And it has a securement mechanism both at the RVOT, ventricular free wall, and posterior septum. So it's not really structured in a way of oversizing. It actually has less than 10% oversizing, putting as minimum as possible radial pressure to the annulus itself. It's flexible and it has the ability to reposition and retrieve itself. And because it has no ventricular sizing, it does not have any ventricular exclusions. So it's indifferent to the ventricular size as well as shape. And we very recently had the honor to actually perform the first V9 for the early feasibility case here in the US with an excellent outcome, and you can see the valve deployment to the left. Last, heterotropic valve implantation. There's 3 different options out there. They're currently being studied and reserved for patients where repair or replacement is not an option. What heterotopic valve implantation stands for is actually forgetting about the tricuspid valve and putting a valve or a device inside the SVC and IVC and kind of controlling the valve function from there. As a result of that, what will end up happening is ventricularization of the right atrium. And it's similar to what surgeons have been doing for years, where in the past they used to excise the tricuspid valve, and a patient would continue living with it. So now we have a 2-valve system where it sits in the SVC and IVC. Limitations of it: ventricularization, as I said, of the right atrium. A lot of the times the SVC and IVC are variable sizes, and so you might need to have custom-made devices that can fit those two. It's currently unknown what the impact of the increase in the RV size and RV failure in the RA will have in the left ventricle and the left atrium. And there's a potential for worsening cardiac output, valve device thrombosis, need for long-term anticoagulation, as well as reintervention in a short time. So there's a lot to be found out in this field, and it's definitely being reserved for patients that actually do not have another option when it comes to replacement or repair. Finally, moving back to our patient, you can clearly see that our main problem was the presence of the pacemaker lead in the area of where we're planning on repairing the valve. So going back to our principles, the gaps looked good, the anatomy had a yellow, leads were definitely a red because it was right at the area we wanted to clip. So we took care of it by trying to reposition the position of the lead across the tricuspid valve. We proceeded with the placement of 2 clips, and you can see we significantly reduced the amount of tricuspid regurgitation, and you can see the location of the clips in the anterior septal and central anterior septal position. We did do some intracardiac echocardiogram in order to further delineate the position of the clips as well as the interaction with the wire and the degree of the tricuspid regurgitation. You can see the decrease from torrential to mild, and at the end we released the wire with excellent results for the patient. So I know we covered a lot of topics this morning, and I'm pretty sure by now you understand that valvular heart disease is frequent in aging population. It's more complex than what we originally might have thought about, and it's definitely getting even more complex as people age. Surgery has been our go-to for a lot of things, but it's not truly an option for all the patients we have. And that's because of age, comorbidities, as well as anatomical factors that make surgery way harder than what we think. Transcatheter therapies, they have the potential to provide options, but at this point, they're not TAVR. We know we're all used to TAVRs being dependable, knowing exactly how the valve is going to behave, and being fast. We're not there yet, and TAVR was not there when it started either. So there are steps to go forward, and we are all learning. We've gotten better in imaging, whether that's an echo, utilizing our CT and understanding better the anatomy and the interaction of our devices with the native anatomy, as well as the MRI, our MRI abilities. We're improving our devices, so we're making devices that are bigger. We're making devices that can accommodate to various anatomies, and we're making devices that minimize interaction with the native valve and the native anatomy. There's a lot of multiple devices that you saw at various levels of clinical trials. Some are approved, some are in the process of larger clinical trials, and some are in the very early stages of early feasibility studies. And most importantly, a lot of the patients that we do currently screen for clinical trials are actually excluded. So in order to move forward, we've got to figure out a way to include more patients and adjust to more pathologies and more anatomies. Otherwise, we're not going to be able to make all these strategies be similar to TAVR. And with that, I want to thank you all for being here today. And I want to thank MHI, MHIF, our research team, partners, coordinators, APPs, everyone for the amazing work they do. You saw a lot of the things we do every day and a lot of the investigational part, and none of it would be an option without the help and support of everyone.
So I'm not a structural interventionist, but when we refer these patients, is there a minimum duration? Someone with severe TR needs to be on diuretics before I send them in, or?
Usually you want to give any patient the best option for like medical therapy to work. So for the research protocol, we always said that they had to be, for triluminate at least, we said that they need to be on a stable dose for 90 days. But if you feel that there is room to up-titrate your diuretics, up-titrate your GDMT. There's no penalty in trying to improve the TR severity with medical therapy and improving the RV function and size. So GDMT is always the first step. And in all the trials, doing any form of intervention did not eliminate GDMT. So if you see all the arms are intervention plus GDMT compared to GDMT alone. So it's always the first step.
Thank you for that. Nice job. I wonder that just in the data that you showed with regards to the tricuspid valve and the disappointing results with surgery that we've all seen over the years, if we're intervening too late, and is there any idea of doing a trial in someone who before they get to the stage where their RA pressure is 15?
Yeah, it is a lot, and I totally agree with you. There's a lot of discussion of are we intervening too late? And as you said, a lot of the studies have not showed favorable outcomes, even regardless of whether it's a device or surgery. And intervening late, where like a lot of the RV remodeling and RA remodeling has already occurred, is a very high possibility. Will that help? Yes. I think that actually starting to look at patients at earlier stages and actually utilizing maybe our MRI better to get a better understanding of our how much is our RV affected at earlier stages would definitely have a lot of favorable, would still be a lot of interest. I think the biggest problem most of the people out there are faced with is the fact that symptoms in tricuspid regurgitation don't really occur until later. So it's a very hard task to talk to somebody for a procedure or any form of intervention when they're barely symptomatic, where they can still go around doing their day-to-day things, and they do have severe tricuspid regurgitation, but in reality that's not affecting what they do. And I think that's going to be one of the big limitations in enrollment. But I do feel that for mitral, things are more straightforward in the sense that people will first develop symptoms and then they start getting the anatomical differences. For tricuspid, I think that the presence of the symptoms is later on, and we'll need to actually try to find earlier markers of tricuspid valve progression before symptoms.
Yeah, thank you so much for your time and expertise this morning. Fantastic presentation. We have 2 virtual questions thus far. The first comes from Dr. Lesser, who says, excellent talk. And his question is the Batman technique your first choice for LVOT modification, and what characteristics are best for it?
Is it our first one? Not right now, no. I think there's very limited data on Batman, and we're one of the few places, if not the first place, to actually perform it transeptally for a native valve. It's been performed before for rings, But when it comes to native valves, I think we're the first place to actually do it fully transeptally. So that would not be my go-to. When do we consider Batman? We consider it when we feel that lacerating the anterior leaflet would be a little bit trickier and might not be successful. So when there's a lot of calcification in the anterior leaflet, especially at the area where we feel that we're going to lacerate. And what we do when we lacerate things in reality is what we do is we put a wire through the leaflet, and then we electrify the wire and we cut it. So imagine having thick calcification on that leaflet. Your wire will just go around it. Your wire will never be able to cut through the deep calcium. And whenever we see those leaflets, that's when we consider doing the Batman technique.
Thank you for that. The next question comes from Dr. Gessel. And he says, his question is, almost all TMVR data at 1 year in MAC and similarly difficult patients have a mortality of around 30% in a very selective patient population as mentioned. The question is, do we have to go back to surgery, or what mortality do we consider acceptable for a patient?
That is a great question. And MAC is a very specific and hard population. Some of the arms, and that's where mitral 1, for example, comes into play, where a lot of their data, if you ask specifically the team also, they'll be, we did not take into account MAC score. So they're hopeful with accounting for MAC score, all the modifications, they might be able to get a better outcome. Nonetheless, as Dr. Guess also said, the look at Tendyne numbers are similar with a higher mortality. Intrepid kind of seems to have lower, at least for the 30 days, and now they're for 1 year data, so that will be something to keep an eye on. And that's why you see all the trials are starting to develop a MAC arm also in order to be able to assess it. And I'm sure like a lot of the surgeons in the room can touch into it a little bit more. It's not that surgery is an easier procedure. I think trying to, as I said, there's two strategies, resect and respect. Trying to decalcify that valve is associated with like with problems of its own, and there is a lot of like limitations that come with it. So it's not that surgery is an easy way for our surgical population also. Definitely, I would not say that at this point, valve in MAC should be the first way for any of the patients. If surgery with a good outcome is an option, that should be the route. And I think we only reserve those interventions for a higher risk population.
Thank you. All right, thank you.